Welcome to today's deep dive. I'm your host, and I'm joined, as always, by our resident expert. And today we are tackling a topic that honestly sounds like a bizarre riddle, but for a lot of you listening, it's a very real, very frustrating daily reality.
Yeah, thanks for having me. It's a tough topic, but a really important one.
So imagine taking a sip of your morning tea, right? It's your usual blend, the one you've been drinking for literally years. But today, as the liquid hits your tongue, it feels like someone slipped a ghost chili into your mug when you weren't looking.
Oh, wow. Yeah, that's a brutal way to start the day.
Right. Or picture waking up with a tongue that feels completely scalded, like you burned it on hot pizza, even though you haven't eaten or drank anything hot for hours.
Mm.
The burning is just, there.
And for a huge number of women, this invisible fire isn't just like a one-off weird morning. It becomes a relentless daily reality.
Which sounds exhausting.
It is. The sensation is incredibly distressing because it often appears completely out of nowhere. I mean, there's no obvious trigger, no visible injury to the mouth at all.
So our mission today is to answer a highly specific but incredibly important question for you. Can menopause cause a persistent burning sensation in your mouth or tongue?
Spoiler alert, it absolutely can.
Yeah, spoiler. But to figure out exactly how and why, we've pulled together a really fascinating stack of sources. We're looking at NHS Trust leaflets detailing the clinical side of things, some deep dive dental research papers, and genetic databases.
Specifically, the NCBI registry for a really interesting gene called GPER1.
Yes, the GPER1 gene. We're also looking at clinical guidelines from the Royal College of Obstetricians and Gynecologists on menopause management.
Right, because we are looking at a condition that exists right at the crossroads of your hormones and your nervous system.
It's like a collision of dentistry, neurology, and endocrinology.
Exactly. It effectively rewires the whole sensory landscape of your mouth.
So we are going to unpack what burning mouth syndrome, or BMS, actually is. We'll look at why the sudden drop in hormones turns your mouth into a hostile environment, the honestly very surprising link between your oral microbiome and your brain health, and then the practical steps you can take to cool the burn.
Yeah, let's get into it. To understand how menopause triggers this, we really first need to define the clinical presentation of this invisible fire.
Right.
So you might see it referred to in the medical literature as glossodynia, which translates to painful tongue or oral dysesthesia. And it generally presents as a very specific triad of symptoms.
A triad, so three main things. And the first of those is obviously the pain itself,
Right.
which the sources describe as a burning, scalding, or tingling sensation, and it's usually concentrated on the tip and sides of the tongue, the lips, or the roof of the mouth.
And then the second symptom is dysgeusia, which is an altered sense of taste.
Oh, like when food tastes wrong.
Exactly. Many patients report a persistent bitter or metallic taste. It's akin to, like, sucking on a copper penny all day.
Ugh, that sounds awful.
Yeah, it's not pleasant. And the third part of the triad is xerostomia, which is the profound sensation of a dry mouth.
Reading through the clinical guidelines, the most frustrating part of this condition doesn't even seem to be the physical discomfort, as bad as that is. It's the whole diagnostic process.
Oh, absolute nightmare. Because burning mouth syndrome is categorized as a diagnosis of exclusion.
Right, meaning they have to rule out literally everything else first. You can sit in the dentist chair in absolute agony, and the dentist will look inside and tell you everything looks perfect.
Yep. The tissue is pink, it's healthy, there are no sores, no redness, no visible physical damage whatsoever.
It creates such a challenging dynamic for the patient. I mean, you have this severe symptom, but your doctor can't see anything wrong.
Right, the physical hardware of the mouth, the mucosal tissue is completely intact.
It makes me think of like a corrupted driver in a computer.
Okay, I like that. How so?
Well, you try to print a document, and the computer keeps throwing a massive error message saying the printer is on fire.
Right.
You look at the printer, and it's sitting there perfectly fine.
Yeah.
The hardware isn't the problem. It's the software, the nerves that are glitching and sending off these false alarms.
That is a highly accurate way to conceptualize it. It is fundamentally a neuropathic pain condition. The nerves themselves are the things generating the distress signal,
Wow.
and we actually see a very distinct daily progression with this glitch. Symptoms are often relatively mild when a patient first wakes up.
Okay, so mornings aren't too bad.
Usually, yeah. But as the day goes on, the sensory load increases and the burning builds, usually peaking by the evening.
Now, the sources brought up something about that daily progression that seems completely counterintuitive to me.
The eating part.
Yes. If your mouth is burning and your nerves are misfiring, You would assume that the friction, the temperature, and the spices of eating food would make the pain way worse.
It makes logical sense to think that.
But the NHS leaflets specifically note that for many people, eating or drinking temporarily relieves the burning sensation. How does rubbing food against sensitive nerves make them hurt less?
It's so fascinating. It comes down to how the human nervous system prioritizes sensory data. It's a concept known as the gate control theory of pain.
Gate control theory. Okay, explain that.
Think about what happens when you bump your elbow really hard. What is your immediate instinct?
You rub it. You just grab it and rub it.
Exactly. You rub the area. You are flooding the local nerves with non-painful tactile signals.
Oh, because the brain only has so much bandwidth to process incoming signals from a specific area at any one time.
Precisely. So when you eat or drink, you overwhelm the trigeminal nerve in your mouth with massive amounts of new sensory input: texture, temperature, taste.
All this normal data is flooding in.
Right. And this influx of normal data essentially closes the gate on the pain signals. The nerves are forced to process the feeling of the sandwich you're eating, which temporarily blocks or overrides that misfiring fire alarm.
That is wild. The brain is essentially distracted from the pain because it's too busy analyzing a sandwich.
Exactly. But once the meal is over and that sensory input stops, the distraction fades and the burning returns.
Which points us toward the root cause. If the mouth is physically undamaged, we have to look at what is causing the software glitch in the first place.
And the demographic statistics on burning mouth syndrome give us a massive clue here. Up to 40% of menopausal women experience some form of this.
40%.
Yep. And it is up to 7 times more common in women than in men.
That severe gender disparity points straight to hormones. I mean, anyone who follows women's health knows that estrogen impacts the entire body, from bone density to cardiovascular health. But the sheer density of estrogen receptors in the oral cavity was really surprising to me.
The mouth is heavily wired to detect hormonal changes. It really is.
So how does that mechanism work?
Well, to understand it, we have to look closely at that NCBI genetic database we mentioned earlier and a specific receptor called GPER1.
GPER1, which stands for G protein-coupled estrogen receptor 1.
Right. Now, for decades, we primarily understood estrogen through the lens of genomic signaling.
Genomic signaling, which is a relatively slow process, right?
Very slow. Genomic signaling is like sending a requisition order to a factory. The hormone enters the cell, it travels to the nucleus, it binds to the DNA, and it instructs the cell to build a new protein.
Sounds like it takes a while.
It does. That process takes hours or even days to manifest physical changes, but GPER1 works entirely differently. It is responsible for rapid, non-genomic signaling.
Okay, so instead of sending a slow blueprint to a factory, GPR1 is acting more like a direct switch, like flipping on a light.
Perfectly said. It acts almost instantaneously at the cell membrane. Estrogen uses these GPER1 receptors to actively regulate the split-second firing of your nerves,
Wow.
and also the day-to-day maintenance of your tissues, which includes your salivary glands and the mucosal lining of your mouth.
So when perimenopause and menopause hit, and estrogen and other neuroactive steroids decline abruptly, those rapid response switches start failing.
Exactly. The nerves lose their immediate stabilizing signal and become highly reactive.
They just start glitching.
Yes, and the clinical research actually outlines a very specific structural mechanism for this. It's often referred to as the phantom limb theory of burning mouth syndrome.
Wait, phantom limb, like when someone feels pain in an amputated arm.
It is the exact same mechanism. So if we look at the anatomy of the tongue, we see 2 parallel sensory systems. You have the chordotympany nerve, which supplies the bitter taste buds at the back of the tongue. And right alongside it, you have the trigeminal nerve branches, which handle pain and temperature sensation.
So they share the same real estate, essentially wiring running through the exact same conduit.
Exactly. Now, those bitter taste buds are exceptionally sensitive to estrogen. When systemic estrogen drops, the taste nerves lose their hormonal support and begin to underfunction.
They start dying off.
Essentially, yes. They undergo a localized neuropathy.
And because they are failing, the neighboring trigeminal pain nerves detect the drop in sensory traffic, and they decide to overcompensate.
Yes. They lose the normal inhibitory feedback they usually get from the taste nerves. In response, the trigeminal nerves crank up their sensitivity. They become hyperfunctional.
So they're picking up the slack, but doing it terribly.
Doing it too well, almost. They begin firing off spontaneous, unprovoked signals to the brain, which the brain interprets as a burning sensation. The sensory math has been disrupted, and the nerves are desperately searching for input.
That beautifully explains the dysgeusia, the metallic taste symptom we talked about earlier. It isn't just a random quirk of menopause.
Not at all.
The patient is literally feeling the sensation of their bitter taste buds short-circuiting as they lose their estrogen support. The system is misfiring as it degrades.
The metallic taste is the direct sensory manifestation of that specific nerve damage.
That is mind-blowing. So we have this profound neurological misfiring. But according to our sources, the loss of estrogen doesn't just cause an electrical glitch. It triggers a physical structural collapse of the mouth's entire ecosystem.
Which brings us to the third symptom in our triad, xerostomia, dry mouth.
Right. Because estrogen receptors are heavily concentrated in the salivary glands, the decline in hormones causes salivary flow to plummet.
And saliva is so much more than just water for lubrication. People don't realize this. It is a highly complex biological fluid. It buffers acid, it remineralizes tooth enamel, and it washes away opportunistic pathogens.
So when you remove that protective baseline, the environment of the mouth becomes highly vulnerable.
Extremely vulnerable.
And this is where the sources introduced the collagen crisis. We're used to hearing about the rapid loss of skin collagen during the first 5 years of menopause. Everyone talks about wrinkles. But the architecture of the mouth, the gums and the periodontal ligaments, is also heavily dependent on collagen.
Yes. The specific mechanism here involves enzymes called matrix metalloproteinases, or MMPs. You can think of MMPs as cellular scissors. In a healthy, estrogen-rich environment, these enzymes are carefully regulated. They just gently trim away old damaged tissue to make way for new cell growth.
But without estrogen to keep them in check,
They go rogue.
they become overactive and start aggressively snipping up the structural collagen of the gums and ligaments.
Exactly. And the physical result of that is
Okay, tracing the path of this research, we need to look at how a localized oral bacterial overgrowth connects to systemic health, because the sources make a massive leap here.
it is a big leap, but a crucial one.
They go from a dry, painful mouth to an increased risk for neurodegenerative diseases like Alzheimer's. How exactly does a gum bacteria end up impacting cognitive function?
Well, it forces us to reframe how we view oral health entirely. The mouth is highly vascular, there are blood vessels everywhere, and when gums are inflamed and receding, they bleed easily.
Right, like when you brush your teeth and see pink in the sink.
Exactly. And that bleeding provides those overgrowing bacteria, particularly P. gingivalis, with direct access to your bloodstream.
But wait, the brain is protected by the blood-brain barrier. It's designed specifically to keep pathogens out of our central nervous system.
It is, but P. gingivalis is remarkably insidious. Research demonstrates it has multiple mechanisms to bypass that barrier entirely.
How does it do that?
It can act like a Trojan horse. It literally invades our own immune cells, specifically the macrophages, and rides them straight through the barrier.
It hijacks an immune cell.
Yep. And if that wasn't enough, it can also release enzymes that directly degrade the tight junctions of the blood-brain barrier. It essentially breaks the lock on the door.
Wow, so once it's inside the brain tissue, what is it actually doing?
It begins releasing highly destructive bacterial enzymes called gingipains.
Gingipains.
Yes, gingipains are proteases, meaning they actively chop up cellular proteins. And in multiple studies, the presence of these gingipains in the brain tissue has been strongly correlated with the formation of tau tangles and amyloid plaques.
Which are the primary pathological hallmarks of Alzheimer's disease.
Exact.
So we aren't just talking about a painful annoyance anymore. Managing a dry, burning mouth during menopause isn't just a quality of life issue about trying to eat a meal comfortably.
No, it's active frontline defense for your neurological health.
You are trying to shut down a localized infection before it has the chance to breach the brain.
Recognizing the systemic implications completely changes the urgency of treatment here. The inflammation and dysbiosis starting in the mouth have direct, measurable ripple effects throughout the whole body.
So knowing that this is a neuropathic, hormonally driven condition with such incredibly high stakes, how do we actually extinguish the fire?
Right, let's talk solutions.
Let's walk through the actionable relief and treatments from the clinical guidelines because it clearly requires a layered approach.
The first step is simple triage. You have to remove any external factors that are further irritating those exposed nerves.
Stop pouring gasoline on the fire.
Yes. The clinical consensus strongly recommend looking closely at your daily oral care products, specifically your toothpaste.
Standard toothpaste often contain SLS, which is sodium lauryl sulfate. That's the chemical foaming agent that makes toothpaste lather up, right?
Exactly. Now, under normal circumstances, SLS is relatively harmless. But for a mouth dealing with neuropathic hyperreactivity, it acts as a severe irritant.
Because the nerves are already screaming.
Right, it can strip away the delicate protective pellicle layer on the teeth and gums.
Mhm.
And the same goes for strong mint flavorings. They provide an overwhelming sensory trigger to nerves that are already firing out of control.
So switching to an SLS-free and mint-free toothpaste removes that daily chemical friction.
It's an easy first step.
The sources also suggest swapping standard mint chewing gum for xylitol-based sugar-free gum. Xylitol is fascinating because it stimulates vital saliva production through the mechanical act of chewing.
Right, you're chewing so you make saliva.
But molecularly, bad bacteria like P. gingivalis cannot metabolize it.
Yeah.
They ingest the xylitol, they waste energy trying to process it, and they effectively starve to death.
It's a very elegant way to hydrate the mouth while simultaneously managing the dysbiosis. Maintaining hydration with frequent sips of cold water or ice chips, and limiting dietary triggers like highly acidic foods, spicy dishes, and alcohol form the baseline of environmental control.
But environmental control might not be enough if the core issue is an internal electrical misfire. For patients who need pharmacological intervention, standard over-the-counter painkillers like ibuprofen rarely touch neuropathic pain, do they?
No, they don't. Doctors often have to look toward medications that alter nerve signaling. One approach involves very low-dose antidepressants.
And to be clear, they are not prescribed here for mood disorders.
Correct. They're prescribed because they alter the reuptake of specific neurotransmitters involved in the brain's pain pathways. It helps to dampen the perceived burning sensation.
The guidelines also mention clonazepam, which is traditionally an anti-anxiety or anti-seizure medication. But for burning mouth syndrome, it's often used topically, right?
Yeah, this is a really interesting application. A physician might prescribe a low-dose tablet for the patient to slowly dissolve in their mouth rather than swallow it.
Just let it melt.
Exactly. Clonazepam binds to GABA receptors. By applying it topically, it acts locally on the peripheral nerve endings in the oral mucosa. It essentially sedates the hyperactive trigeminal nerve without causing intense systemic drowsiness.
That makes a lot of sense. We also see gabapentin highlighted in the Royal College of Obstetricians and Gynecologists impact paper. Gabapentin works by calming the calcium channels in the nerves, reducing their ability to fire erratically.
It's a heavy hitter for nerve pain.
And the RCLG paper noted it effectively reduces vasomotor symptoms like hot flashes and improved sleep, while simultaneously dulling that nerve pain.
It does. But while gabapentin is a highly effective tool for symptom management, the RCOG guidelines point out that addressing the root cause, the actual estrogen withdrawal, is often the most definitive path to relief.
Which brings us to hormone replacement therapy, HRT. If the nerves are screaming because they lost their GPER1 rapid signaling support, does systemic HRT restore that function and stop the burning?
The clinical data on HRT specifically as a standalone treatment for burning mouth syndrome shows mixed results in broad population studies. So it is not considered a universal cure.
Okay, good to know.
However, the mechanism of action is undeniable. For many women, once their systemic estrogen levels are stabilized through HRT, they experience significant, sometimes life-changing relief from the oral symptoms.
Because they're replacing the lost hormone.
Right. They restore that non-genomic signaling and repair the structural integrity of the mucosal ecosystem.
Beyond pharmaceuticals, the literature heavily emphasizes nutritional support. Deficiencies in B12, iron, zinc, and folate can degrade the myelin sheath around nerves, which obviously exacerbates the pain. But one of the most highlighted supplements in these dental research papers is alpha-lipoic acid.
Yes, ALA. Alpha-lipoic acid is a highly potent antioxidant. To understand its role, we have to look at oxidative stress.
Which is when the body's under duress.
Right. It produces free radicals, which are these unstable molecules that steal electrons from healthy cells, causing direct physical damage to nerve tissues.
And ALA acts as a scavenger, neutralizing those free radicals before they can attack the trigeminal nerve endings.
Exactly.
Which ties directly into the final and perhaps most complex component of treatment, the psychological aspect.
This is where a lot of patients feel misunderstood.
I can imagine, because when patients with physical pain are advised to try stress management, it often feels dismissive, like they're being told the pain is all in their head.
It is a profound failure of medical communication. The pain is completely physical. but the biological mechanism linking psychological stress to physical nerve pain is very, very real.
It involved the HPA axis,
Yeah.
right? The hypothalamic pituitary adrenal system.
The body's primary stress response system. During the inherently stressful, often sleep-deprived years of perimenopause, chronic anxiety keeps the HPA axis activated. It floods the body with cortisol.
And high cortisol levels drastically increase systemic inflammation.
Yes, and they exponentially increase the production of those tissue-damaging free radicals we just talked about. Your psychological stress is chemically translated into molecules that actively erode your nerve endings.
That is a critical connection to make. So when clinical guidelines recommend cognitive behavioral therapy, or CBT, they aren't suggesting that positive thinking cures a burning mouth.
Not at all.
CBT is used as a clinical tool to promote neuroplasticity, helping to physically downregulate the nervous system.
Exactly. By changing how the brain responds to stressors, you lower cortisol production, which physically reduces the free radical load in your body and thereby lowers the actual perception of pain.
So to truly extinguish this fire, it requires attacking the problem from multiple angles.
Absolutely. You are managing the immediate environment with xylitol and gentle toothpaste. You're addressing the electrical misfire with gabapentin or clonazepam.
You're potentially repairing the hormonal root cause with HRT.
And you're lowering the oxidative damage through alpha-lipoic acid and stress management.
So to summarize for you listening, the burning sensation, the metallic taste of old pennies, the profound dryness, it is an entirely measurable neuropathic condition.
It is not in your head.
It's triggered by the withdrawal of estrogen, which fundamentally alters your taste buds, plummets your saliva production, unleashes rogue enzymes on your collagen, and leaves your nerve endings exposed and highly reactive.
And because it compromises your oral ecosystem, it allows pathogens like P. gingivalis to thrive and potentially cross the blood-brain barrier.
So seeking comprehensive treatment isn't just about mouth comfort. It's about protecting your long-term cardiovascular and neurological health.
It really highlights how intricately connected the systems of the body truly are.
It does. And there's a thought I want to leave you with, something that became very clear reading through these sources. We've established that the estrogen receptors in the oral cavity are incredibly sensitive.
Very sensitive.
So sensitive that they often begin glitching and causing this burning pain as soon as hormone levels begin to subtly fluctuate.
Which often occurs long before the classic hallmarks of menopause, like severe hot flashes or the cessation of menstruation, even begin.
Right. So what if, in the near future, dentists become the frontline healthcare workers for perimenopause?
That is a fascinating concept.
Think about it. A routine dental checkup, or a hygienist spots unexplained rapid gum recession, a sudden drop in saliva pooling, or a patient casually mentions a new metallic taste. That could serve as an early warning system.
The dentist could be the very first medical professional to look at the clinical picture and suggest an endocrine evaluation.
It represents a massive paradigm shift, treating the mouth not just as an isolated system of teeth and gums, but as a highly sensitive diagnostic mirror for the body's entire endocrine health.
I love that. It's a completely new way to look at preventative care.
So the next time you take a sip of tea and feel that unexpected ghost chili bite, remember, your body is trying to tell you a complex story about your hormones. You just have to know how to translate it.